knee replacement in general entails basically the resurfacing of the surface of the joint, in this case the knee, with metal and plastic to allow the patient to go from having an arthritic joint to a joint that's more functional and less painful. A lot of people have a misconception that a total knee is actually removing the whole end of the thigh bone and the whole top of the shin bone. And essentially, it really is a misnomer. It should really be called a total knee resurfacing, because really that's all we do, resurface the end of the joint with a prosthesis. So for instance, on the femur or on the end of the thigh bone, we essentially place a metal cap on the end of that bone that then becomes that patient's articular surface. Okay, we don't do anything to the ligaments on the outside or the inside part of the knee. The ligaments in the middle of the knee we have to sacrifice usually in order for us to be able to put the prosthesis. But the prosthesis itself then serves as the ligaments. So bottom line, total knee replacement is a procedure that allows us to resurface the end of the thigh bone on top of the shin bone in a way that we can allow patients to have a more functional joint. There are also things called partial knee replacements, where we only replaces parts of the knee, so either the inside or the outside part of the knee joint or underneath the kneecap itself. The number one reason to have a knee replacement is pain. Secondary to that is loss of function. We try to maximize all conservative measures prior to that. So we do anti-inflammatories, we do certain types of injections, physical therapy. Once patients have maximized all those things and they're still having considerable pain, then they become a candidate. The things that I look for in patients are pain that wakes you at night or keeps you from sleeping, pain that causes your knee to give out on you while you're walking or doing just menial tasks, pain that starts causing problems or pain in other parts of your body. So your knee hurts, so you limp, then your back starts hurting or your hip starts hurting. And then finally, pain that's limiting or affecting your quality of life in a way that you don't want to do the things you really enjoy. And all those things are after you've tried everything else. So it really is kind of the last ditch effort in order to give you pain control and subsequent to that, better quality of life. Well, one of the things that we really have worked hard on is something called minimally invasive surgery. That doesn't only involve the invasiveness of the incision itself, but also involves the preoperative, intraoperative, and postoperative analgesic control. So we do a lot of things even before surgery to help patients with pain control. Specifically, we do nerve blocks, we do injections in the knee during surgery, and then we do postoperative pain control. So typically, the pain after surgery is actually less, a lot of times, than the pain from the arthritis that the patients have. So from the standpoint of how much pain it is, it is a surgery, and it's a major surgery, but it's very tolerable with oral medications. The biggest risk factor from any prosthesis, be it a knee replacement, hip replacement, heart valves, is infection. Because anything mechanical where the body doesn't have blood supply, and so your body's immune system fighting that off, very difficult. The other risks that we have with knee replacements specifically are blood clots, or deep vein thrombosis, and the risk from the anesthetic itself. Patients often can have complications that cause their knee not to feel like their own knee, so their knee feels stiff or continues to be painful. Those are the major things that we try to avoid. Overall, any major complications such as infection, blood clot, it's about 1%. So it's not a very high risk. We've been doing knee replacement long enough. We've really fine-tuned things well enough that we can control those things. Obviously, there are risk factors certain patients have that make them higher risk for things. Diabetes, being overweight, those kind of things. So the risks are low, and we do a good job controlling them, but they're not very common. Typically with knee replacement surgery, we tell patients that we hope that their joint will last them 15, 20 years. So we hope that there's not a need for having follow-up surgery. We have better materials these days than we had even 5 years ago, especially 10 years ago. And what I tell my patients is at 10 years from the time of surgery, 95% of patients still have the same knee they had in. And then it decreases to about 1% per year. So at 15 years, 90%, 20 years, 85%. So our goals are to get patients a 15, 20-year knee with the technology that we have. The other good thing about knee replacement surgery is the prosthetic itself is what we call modular. So for instance, on the shin bone part, there's a piece of plastic that serves as the new articular cartilage. Well, on that particular piece of, on that particular prosthetic, this can be changed in and out. So let's say 15 years from now, the patient starts having increased wear, you can go in and change this. I often tell patients it's like, but going in and changing your tire. So once it starts wearing out on you, go and get a retread and you're good to go. But that's something that we have to pay attention to and follow up on closely. Being a joint specialist who specializes in hip replacement and knee replacement, I see all comers. On average, most female patients are around the age of 65, and most male patients are around the age of 62, 63. I have patients everywhere from, super high-end athletes who've been very athletic all their lives to grandma who's 85 years old, who's gone along with her arthritis as long as she can, and she can't tolerate it. So once again, the number one indication for knee replacement surgery, partial knee or complete knee replacement, is pain. So that's our number one goal, and the pain from their arthritis.